everyone, my name is Kishni Lovina Thiagarajan from Kuala Lumpur Metropolitan University. Here I'm going to present my case presentation for geriatric. Here we go. Demography data. Patient name is Auntie Chan. She is 73 years old. She born on 1994. She's staying at Klang Jaya. She's a Chinese Buddhist lady. And the language that she prefer more is Mandarin because she's not good in other language, but still can communicate in Malay. Status she already married. Right now she's not working, and also right hand is her dominant hand. The date of she referred to OT is on 4th April this year 2017, and her diagnosis is depression. Definition of the diagnosis. What is depression? Depression is a common and serious medical illness that negatively affect how you feel, the way you think, and how you act. Fortunately, it is also treatable. Depression causes feeling of sadness and or of loss of interest in activity once enjoyed. It can be linked to a variety of emotional and physical problems, and can decrease a person's ability to function at work, at home, and so on. Depression's symptoms can vary by from the mild to severe and can include it. They start from the mild, feeling sad and having a depression notes, loss of interest or pleasures in activity once enjoyed, changes in appetite like loss and gain related to dieting, trouble sleeping or sleeping too much, lost weight, lost energy or increased fatigues, increase in purposefully physical activities, handwriting or spacing or slowing movement and speech, acting observed by others, feeling wordless or guilty, difficulty in thinking, concentrating or making decisions, thoughts of death or suicide. Thought of death is suicide is that is a severe part. Suicide attempt that is severe that it can be major depressions. So now the factor for depression is environment, personality, genetic and biochemistry. Biochemistry different in certain chemicals in the brain may contribute to symptoms of depressions. Genetic depression can run in family. For example, see if one genetic twin has depression, the other has a 70% of chances having the illness sometimes in life. And personality, people with low esteem, self-esteem, or who are easily overwhelming by stress, or who are generally appear to be more likely to experience depressions. Environmental factors is continuous exposure to violence, alleged abuse, or may make some people more vulnerable to depressions. Personal history of my patient's Auntie Shant. Auntie spent her most of time at her home with her husband. Auntie likes to go for Tai Chi in the morning with her friends. And she don't like to watch television because she said that no use to watch the televisions. Auntie enjoyed a life routine with peacefully. Auntie staying with her husband her only her marriage so that she have to do an area by herself. Maximum time she have nothing to do, just feel free. And her husband can drive so it's easy for her to get some. where she wanted to go or come to clinic or rehabilitation centers. That is a simple things of personal history of aunties. Now let's look for family history of Auntie Chan. When she married with uncle and she have only one daughter and she married. The daughter also married and she got three grandsons and her daughter was staying far away from auntie, but her daughter is always come and spend time or take her to her home to live with her. So auntie also got spend time in her daughter house, and in previous years she got to look after her grandchildren, but right now they all grow up already, so she just go and spend time with them. Case history about Auntie. Auntie Chan family don't have any illness problem. Auntie Chan have own assets such as house and car. She was good in cooking too. She liked to look after her grandchildren as well. She very good in cooking. Whenever she came for rehab, we was do some of events in our rehab. So she was really active in cooking parts. She was volunteered to do all the cooking parts. She can teach for others during the cooking events. She's very active one. Now medical history of Auntie Chan. Auntie Chan having depression and having medication currently. Otherwise, patient is she's physically good and has no other medical illness. So that is some plus point of her. This is the depression is the medical issues for her. Otherwise, no other illness. Education history. Auntie complete a school standard 3 at Sekolah Kebangsaan Kelang Selangor. Auntie also have some working experience. She got work before this. She just work at home, just making helping stuff and doing just do stuff at home and send to the factory. That kind of things that she have to do. Specific history of auntie. Pre-profit or post-profit heart of sales. According to the client, she is still in the same character. Client likes to be touchy and close with his whole friend and new friend. She's very friendly type because she's the most of time when she want to go out like rather than she expect her husband. She also spend a time with friends to go out like for tai chi, even go for market to buy stuff and for cooking. When to go for temple also she will follow her friends like that. So not the most of them like even at home she stay at husband, but rather than that she also spend at outside times. Now the part of evaluations, subjective assessment for Auntie Chance, speech and communications. Okay, Auntie not good in communication English, but she still can manage to talk in Malay. If there is a husband with her, she talk less and let her husband answer for her. Client able to communicate with therapists and students. Easy to understand with what patient have been said because she used simple words of Malay so she can understand. She can occupy her phone very well so that she can talk through by the phones. Verbal. Patient able to understand and to respond by verbally. Performance. She can independence without her husband as well. She can follow the instruction in one time way. She can perform well in her activity and tasks that given to her. The continuous of the subjective assessments. In general appearance, patient is neat and tidy. She can walk independently. No physical disability and impairment has been since. And gait also slow and shorter but can walk quickly. Likes and dislikes. She don't like to eat meat. She prefer more vegetables. She like to spend his time in park in morning near to her house. She spend her free time with some productive activities such as like blanket, pillowcase. Subjective assessment continues is on the mood and personality. Client is a good motivational during therapy sessions and relationship with therapist. Patient is able to cooperate and able to understand and follow the instruction during the therapy sessions. Objective assessment. We assess on occupation performance area OPA in non-standardized observation and interview. And also we use some standardized assessment like occupation questionnaires. We assess activities of daily living. She was able to do bathing, bowel and bladder management, dressings, eating, feeding, functional mobility, personal device care, personal hygiene, and grooming. Everything she can score full marks because everything she do by herself, never expect from others helps. And we also assess on instrumental activities of daily living, IIDL. We use non-standardized and interview observation tool. Assessment, standardized assessment that we use is occupation questionnaire. And communications management, okay, still can works. And meal preparation, cleanups, religion observations, financial management, health management, and maintaining responsible for own medication she can take by herself. And home establish and manage laundry, housekeeping, safety and emergency maintenance, shoppings, everything she can spend, she can go anywhere she want to do, whatever she need and wants. She's called everything full mark actually here. Rest and sleep in occupational performance area, the third things. Rest and sleeps, we use non-standardized and interview and standardized assessment from occupation questionnaire. Sleep participation, she can take care of her personal needs of for sleep, such as she consists of activity to ensure onset of sleep, napping, preparing for the physical environment, such as setting on alarms, securing the home, such as locking the door and closing the windows, the curtain, and turning off the electronics and lights before she go to bed. She also take nap at 1:30 to 2:30 minutes for the naps on afternoons, and she also sleep early because she take dinner early at 7 somethings and she was go to bed at 8 o'clock. At 8 o'clock and she wake up at 5 o'clock. So she sleep 9 hours. Very good sleeping hours. Sleeping hours is not a problem with her. She really participating very well and very independent on this part too. Okay, the fourth area of occupational performance areas, that is leisure. We use non-standardized assessment as interview and standardized assessment occupation questionnaire to observe these leisure parts. She can able to do knitting the blanket for her own use and the family members at the home when she was free. Sometimes also she do gardening in her home environment, but very rare in gardening. Sometimes only, not always she spend the gardening, but she the most leisure things also very less, so not really participating much on these parts. Okay, the fifth area is the social participation in occupation performance area. That is, we use non-standardized assessments, interview, and standardized assessment is occupation questionnaire. Community, she can engage the activity with neighborhood, good interaction with neighborhood and friends in the parks. Family, she can spend time with her daughter, son-in-law, grandsons, and her husband. Friends, she spend time with her friends such as going to temple, market, go for tai chi, exercise, all the stuff near to her homes. Now, occupation performance components under objective assessment. Let's have a look on it. More details. Okay, the first one, the cognitive functionings component from the occupation performance components areas. So follow the instructions. Yes, the method that we use is non-standardized assessment through the observations. And the result was client is able to follow the instruction during the therapy section because whatever we give her to do, she just can follow just in one time instruction she can do really. So really, really good in instruction, listen to the instructions. And the attention and the concentrations. He used non-standardized assessment through the observations too. She is able to do and focus to complete the tasks that have been given to her. So she really got the way. The second component of performance components areas is the psychology functioning and psychosocial functioning. This is an assessment for geriatric depression scale that we can assess the depression scale for geriatrics, special for geriatrics, our elderly peoples. So they can have a look on this assessment. Here is the assessment result. Geriatric depression scale. Based on the GDS assessment done, patient has been obtained to 3 over 15 has the score and is considered as a normal. And from the psychology functionings method that I use is non-standardized assessment through the observation and interview of the clients. Client, the result is client good of motivation to do any task at home and Johnson's Rehabilitation Center without a complaint. And however, patient shows a good motivation during the therapy session because there is a therapy so students stand by and clients will appreciate the departments too. The third area, neuromusculoskeletal. So the area they want to focus is on the range of motion. Full range of motions on the both upper and the lower limb. Patient is able to move the upper and the lower limb freely without any difficulty. Because even when she come to our center, because our center is on the second floor, she used the staircase to come out. Since she is like normal only, no tire or no feel pain, she can still can walk up, go down and go up free. So no problem on the range of motions. Endurance sparks energy, so we use non-standardized assessments also to the observation during the therapy session and the interview. And standing, we focus for physical activities on the standing and the sitting parts. Static client is able to stand with no supporter. Client is able to stand more than 10 minutes. Patient is able to stand the dynamics. The static client is able to sit with back support more than 30 minutes and client is able to sit very well. The dynamics is the gross motor coordination. Patient is good in upper arm functioning, standing, sitting, and walking independently. And for the fine motor coordination, patient good in the hand manipulations. Patient is able to use the finger and hand finger knitting section, no shaking at all. She can cut the staff of therapy section with a scissor with nice based on the lines and good bilateral hand use during we observe for good bilateral hand is when she using the finger knitting, she able to do very well without missing any single steps. So really good in bilateral hands use. Okay, for sensory motor, we use sensory processes. So we focus on tactile and proprioceptions. The method that I use is non-standardized assessment. Patient eyes is closed and differentiate the feeling of sharp and dual objects like safety pins and tests on the patient on 5 times hands. The score is 5 for whole patient is good in tactile. She can feel rest and pain and there it was the things that we have been tested. So really good on this part. And the second thing is the proprioception. The method that I use is non-standardized assessment, and we hold the patients dominant hand, upper limb, and move the joint in flexion or extension with patient visions is excluded. Then patient has to indicate the flexion or extension in another upper limb. Examination of so 5 times, she scored 5 or 4. Patient in intact in preposition and shoulder and elbow tube. So right now we are at the problem identification. So occupational performance area, the problem that find out is the lack of leisure activities. Patient has lost interest in pursuing most activities because of the aging. And on the occupation performance components, she have to maintain the cognitive level and maintain the social skill too. So we are here at the treatment plan and goals. Our short-term goals for Auntie is to maintain and improve the patient cognitive skills and to maintain the social skill of patients right now. And for the long-term goals to improve client productivity and increase and maintain the participation in leader activity. So these things can improve or can reduce her stress level. I think so. Treatment model frame of reference approaches. So model of human occupation, MOHO. The model of human occupation, the model look at how human behave at this pattern and performance using three different factors, the violence and habituations and the performance capacity and evaluations looks at what motivation a person to perform certain acts. Look at the process and the pattern that develops from the process of the act and performance capacity identifications and the method and the physical skills of person has to perform in certain acts. So the frame of reference, the form, is humanetics form. Humanetic is an approaches in which the empathy or human value to others is applied in the comprehension phase. Humanetics approaches is a basics of complex physiologies and empty through the thinking as humans. In this way, this approaches is optimized and focusing on the ability of the human to solve any problems. And rehabilitation frame of reference. Rehabilitation is the process which helps an individual to be independent, to perform the daily activities and social interaction with his or her abilities. For this frame of reference, gives educational adaptation techniques, assistant device, and social and physical modification to improve the functional to perform any activities. A biomechanical frame of reference used to treat an individual which has limitation in doing any activities caused by dysfunctions of structures and the function of biomechanical bodies such as limitations of frame of motions, low endurance, decrease the strength and uncertain structures. And also the cognitive frame of reference is assessing the level of cognitive functioning and providing the tasks and predictive to the level aim to describe the cognitive limitation caused by the chronic illness, identify the remaining function ability so the expectation of client are realistic. Cognitive frame of reference, 6 level cognitive level, attendance, appearance, purpose, experience, behavior during the process of X. The goal is to provide the means for the task to be adapted and to match the maximum ability of the individual. Provide the guidelines for enabling clients to function without putting them under the stress. Behavioral frame of reference in these branch of psychological that studies in interaction of the persons and this environment. The behavior can occur in three distinct ways: is classical or responsive constitutions and operator and instrumental conditions and model learning skills to support the appropriate behavior. Goals are to promote and product the personalizations and behavior of individual. The procedures when using the conditions and model in the public can facilitate more positive customers and their clients. For example, individual with cognitive defiance, young children's client with a lack of motivations. This is a part of behavior cognitive frame of reference. Some of the approaches to share that is a family-centered practice. Family-centered practice is the characteristic by appreciating and valuing of the family, Concerns of priorities, family support, and family education. The therapy who practice family-centered care seek information about how the disabled impact family occupation, what occupation are important to family, and also the education approaches. These approaches focus on the importance of education for the patients and family to perform most of the activity independently, such as energy conversions and birth simplifications. Complementary biomechanical approaches focus on functional movement and purposefully activities such as organized influence on the movements, modifications of activity to improve the performance. Okay, sometimes physical dysfunctions can be everlasting, then these approaches is used to use any adaptive device to return and strengthen the independence to perform their daily living activities service and increase the patient independence. And this approach is really good for patients around us. So behavior approaches can help a child to achieve the higher level of performance through a process of calling shopping. And this is the shaping is involved breaking down and complex behavior into a components and reinforcing each behavior individually and systematic under the process of behaviors. So cognitive approaches are top-down or occupation-based approaches because this emphasizes therapy sense assisting to the child is definitely developed in his cognitive functions performance daily occupation effectively. And the occupational therapy designed the interventions to increase the child's repertoire of cognitive changes and improve the child's ability to select, the monitor, and evaluate his or her use of these strategies during his performance of task. The cognitive models of frames practice of requirement that is therapy identifying and use the global problem solving strategies which is provide a consistent frame of readings which a child discover a specific strategies and verbal tasks that he or she either needs to want or to perform. Okay, treatment implementations. Here we are. Let's go through with these things. We move with the problem, patient difficulty to pursue the leisure activity due to lack interest because of the depressions in having these problems. So our treatment is leisure activity. So to continue and improve the leisure activity, this is the terminal behavior and the aims to focus on this problem. And the condition and the method we're going to use is outing with family. This is the things that she already doing, but she still have to improve at this part. And picnic, gardening activities, choose the plants, like stepping and gardening, putting everything, plastics for plants, move the plants. So this is what she has to go through, more things. Okay, watching movie, classic movie, knitting, cooking. So this part of this method can like really help her to make her because she is very interested in this part too and like cooking, knitting she likes. But sometimes she is like just like give up to do the things. So have to focus more on this part. The criteria is for just like for 1-2 hours per day. That is good enough. And the rationale for this treatment is staying engaged in life with the activity and relation is directly related to cognitive and the satisfactions. Rating is increase the hour of the activity. The precaution is safe environment. That is the most important. Whenever she want to do any activities, the environment is most important. So that because she is an elderly patient, so it's very important. Here we are for the treatment plan. Let's have see this all. The treatment plan for this problem, cognitive impairment, lack of information. Because she studied until standard 3 just for 3 years, she joined the school and she was not really good in informations like cognitive things. So we plan to do cognitive training 2 years to maintain the cognitive functioning. Right now she is able to share some information but still need the more information too just to because she's getting elder so we have to focus on these cognitive things. So we plan to do like some kind of activities for her like a bingo. So it will be pay attention the number of being called. So this part and the criteria is for 30 minutes per sessions. Maybe she can do once a day or twice or 3 times in a week. It's a good too. Because she already came for rehab already, so we are trying to do more things also. And the rationale is multi-instructions teams research report that although adults are participate in mental exercise program report the less difficulty in everyday tasks living by those who are had participations. And reading is simple to complex, and precaution is speak with clear speech and prefer for quiet rooms so she can focus much. Okay, is now the third problem is social skill to improve her social skills because she's spending the time in house with husband alone, so it may cause more depressions. So that right now her depression level is even more normal, so that we have to maintain the normal level. So we try to give her more social skills input so that she will come out from the house. So she spend the time for social participation. So it can be, the depression levels can be forgot about things, so we focus more and our treatment try to improve our social skills and the condition and mental are relevant. The treatment is related to more to social skill activities like this participation in our rehab events and more activities in social things because we are more focused on social things also. And also the criteria is for 1 hour sessions and the rationale for this treatment is social skills. Training consists of learning activity utilize the behavior technique that enable the person with depression and other disabilities to acquire the interpersonal device management and independent living skills for improved in functioning in their community. A large of growing body of research support the effective and effectiveness of the social skill training for skills also. And this the type and frequency of training is the link to the process of the disorders like patient can learn and retain a wide variety of social independent living skills and generalize of the skills for use in everyday life course when the patients are provided with opportunities and encouragement and reference for practicing skills and relevant situations too. The precaution, the grading part is increase the number of member of the groups. So we plan this to increase the number when because she already now is the have a maximum number. So just add more numbers to it will help her too. So got many friends, she can spend more time with them. And the precaution is be aware of the speech and select the condition of a population too. So the future plan is to visit Chanka rehabilitations and continue the treatment as above and to reassess the patient if possible and do further assessment too. Patient assets is patient is able to follow the instruction and patient is able to complete the task that given to her. Patient has no any severe illness. Patient is able to sit and stand for more than 5-10 minutes. So patient can able to complement and the treatment given to the by the students. Patient here to occupational therapy program. Patient is very cooperative with the student during the interview sessions. Patient has good financial support from the family, especially from the doctor and the husband. Prevention of the auntie is good because patient has no other physical severe illness. Patient is very good self motivation person. Patient has good financial support from her doctor. Patient complement with treatment session. She's very cooperative with these professions. And right now she improved a lot and she really good. So here we are at the last part of the reference. And for the intervention part and to do this prepare these slides I have to refer some of the things and the links and books too. So here we are, you all have to look through here also. Okay, I would like to thank for everyone to listen this video. Thank you so much and take care. Bye.